international human rights organisations as a right, but it's very difficult to see how the right to health can be provided for in the context of the 8th Amendment. Maybe you might speak to that a little bit, and how you might differentiate between serious risk, or should you be differentiating? Should that be something that is very much down to the clinician and the woman involved?
You know, I really believe this is where clinicians and their patients need flexibility to look at the implications of health issues during pregnancy. Some women come into pregnancy with conditions like cystic fibrosis, portal hypertension, and there may be really significant risks of that woman dying because of the additional physiological burden of pregnancy. Similarly, women can become ill during pregnancy, and we need to interrupt the pregnancy prior to fetal viability. Once fetal viability is achieved, we can deliver a baby because of either maternal or fetal disease, and as I said, we do that all the time, and 2% of deliveries in this country occur early, before term, because a woman or a baby is ill, and we can deliver before term. But it's really prior to viability that the problem arises, when we don't have the option of delivering her baby, and in those cases we have to look at what are the risks to that woman, and that's where clinicians need flexibility. I don't think it's appropriate that we somehow have to wait until a woman is at a substantial risk of dying, because how do you define that? As I said, what is a substantial risk? Is it 5%? Is it 10%? Is it 50%? And what of a woman's view? If I say to you, you've a 10% chance of dying, but I'm okay with that, you might really disagree with that and say, well, doctor, I'm not okay with that. And so this is real-life medicine. We cannot predict clinical course all the time with exact precision. We have clinical evidence, we have likelihoods, we've got probabilities. And therefore, what clinicians and their patients require is flexibility.